I do need to just bring us all in because we have such a phenomenal last plenary here, incredible speaker. But before, oh, look, there we go. Okay, we're clapping. All right, we'll do that. Okay. All right, so if you have painted a canvas in the wellness room, they are at the registration desk in the lobby. There's a lot of unclaimed canvases. Now, I am not sure if you don't want your canvas or if you just forgot it. So please go down there and pick them up. They're beautiful. And then also, the evaluations. Always got to talk about these. But remember, for your CEUs, you need to complete that final evaluation. That was emailed to you this morning. And then also super excited to announce our next year's conference is going to be August 19th through the 21st. Somehow it's going to be 2025, which is just seems like a typo, but according to everyone, that is actually the date. So yes, August 19th, 2021. And 2021. Thanks, Janelle. 2025. But for that, we have all these amazing, look at all the bingo cards. Good job, everybody. So I am just going to randomly pick one. All right. And you have to be present to win, so sometimes this could be like 8 draws. So don't be disappointed if you're not the first name. All right, the first name is Marlise Perez. Come on up. Okay, I'm coming. Sorry, I'm going to be here anyway, so. Okay, it's Laura Sullivan. Is Laura here? Woohoo! All right, Laura. So I'm going to take your card to the registration desk. Just talk to Kara, and she will be in contact with you on the first time. That's so exciting. Yay! Awesome. And so before I introduce Brian, I do just want to say really quick and acknowledge there's been a lot of, oh my gosh, just went to the most amazing workshop about burnout. Anybody else in the burnout workshop with me? Incredible, yes. But one thing we're just talking a lot about is valuing people. And so I really cannot end this day without valuing my team, but I do just want to highlight a few of them in particular. Denise, Javon, Tyler, and then of course Kara and her team for putting all of this on. So if you guys please stand, I just want to make sure everyone can acknowledge you. They do all the work. So thank you all so much. And then with that, I am pleased to talk a little bit about our next speaker, Brian Hurley. He is an addiction psychiatrist and the medical director of the Bureau of Substance Abuse Prevention and Control in the Los Angeles County Department of Public Health. He is Los Angeles County's lead for the Substance Abuse Mental Health Services Administration's first harm reduction grant program and the current round of the Centers for Disease Control and Prevention Overdose to Action Local Grant Award. So with no further ado, I'm just going to ask Brian to the stage.
Good morning. Can you hear me okay? All right. You should be looking at a slide that says the ASAM criteria, 4th edition, implications for California's drug Medi-Cal system of care. Before I get into the details, I am not going to try to sell you anything today. I don't make money off of ASAM or the 4th edition, and I'm the president of the American Society of Addiction Medicine, ASAM. So, I'm not unbiased with respect to ASAM or the ASAM criteria, so you should know that, just up front, that's where I'm coming from. Now, I also live and work in LA County for the Department of Public Health, medical director in our drug Medi-Cal system of care here in LA County. And so I have the dual privilege of implementing the 4th edition as a county behavioral health system and representing ASAM in making sure that people understand and implement the 4th edition with fidelity. So I'm sort of here with my ASAM hat on, but I'll give you commentary from the county perspective. The ASAM criteria. First of all, how many of you have heard of the ASAM criteria? Awesome. Yeah, I mean, it's in law, so that would, that helps, that it's part of California statute, right? But the ASAM criteria really is designed to create a consistent way to assess patients' biopsychosocial circumstances to identify an appropriate level of care. In addition to being the source of medical necessity, right? What's the right care for the right patient at the right time? It also informs what are the individualized components of care, which medications are appropriate, what types of counseling and psychoeducation is appropriate, what other housing or other social interventions are appropriate. I sometimes get asked, Dr. Hurley, what's the right amount of residential care? Is it a 28-day program? Is it a 90-day program? Is it a one-year therapeutic community? And I say, the right amount of residential care is the amount the patient needs, according to the ASAM criteria. Because the ASAM criteria is actually oriented directly, if I could say so, against a program-centered design, right? Some patients need more than 90 days of residential. Some patients need less than 28 days of residential. It sort of depends on the patient. Some patients don't need residential at all. The ASAM criteria is the guide that helps us match what's the right patient for the right level of care, for the right duration, and then what are the indicators as a patient is receiving treatment and responding to treatment for what happens next. That's what we mean by individualized care, right? We're not delivering program-centered, this is the fixed duration of care, but we're continually reevaluating the patient for what's the right amount of care for how long. And it guides clinicians and care managers to make objective decisions around admission, continuing care, and movement along the continuum. Addiction is a chronic medical disease. All right, when you are done with a certain level of care, it does not mean you are done with treatment. It means you are ready to move on to the next level of care. And kind of like we do in primary care, where the treatment for diabetes, which is a chronic medical disease, is ongoing. The treatment for hypertension or high blood pressure, which is a chronic medical disease, is ongoing. The treatment for addiction is really designed to be people working a recovery program kind of indefinitely. Now, that doesn't mean that they're in a given level of care indefinitely, but that just means people are continuing in their recovery as ongoing management of the disease of addiction. The principles of the ASAM criteria is that admission is based on patient needs, right? So it's not necessarily a fixed checklist, but that there's an element of what does this patient need at one time. The multidimensional assessment, there remains 6 dimensions in the 4th edition of the ASAM criteria, look at biological, psychological, social, and cultural factors that contribute to addiction recovery. Plans of care are individualized based on the patient's needs and preferences, and the care ideally is delivered by an interdisciplinary team, right? So you've got medical clinicians, licensed clinicians, you've got registered and certified counselors, your peers, right? That there's an interdisciplinary team surrounding the patient. And co-occurring conditions, that is people that have co-occurring mental health conditions along with their addiction, is the rule, not the exception. I can't think of anyone I know who's been to treatment that is sleeping very well or has no mood or anxiety features. Now, that doesn't mean that they have co-occurring insomnia or a non-SUD related mood or anxiety condition, but it is worthy of exploring that and seeing what are the other mental health service components that would help support this patient's recovery. Patients move along the continuum based on their progress, not on, well, it's day X, so it's time for you to go, right? It's not program-centered, it's patient-centered, which is a point I'll probably keep making again and again over the course of this talk. And then informed consent and shared decision-making accompany treatment decisions. So here is essentially those words written in graphs or in figures. So there's a level of care assessment, a set of decision rules or decision logic that then inform where somebody goes in the continuum of care. There's another assessment that then determines decision rules that determines level of care, and it's this ongoing sort of transition or ongoing assessments or reassessments that then guide where the patient goes next. Currently, in August of 2024, I think I have the month of the year right. So in August of 2024, We are in a third edition world, right? The DHCS licensing is third edition. The drug Medi-Cal certification is based on third edition. We are in a third edition framework. The goals in transitioning from the third to the fourth edition is to update the standards based on what we know about the science of addiction, to support a more chronic care model rather than the idea that you get a dose of addiction treatment and then you stop, but rather that you get a dose of addiction treatment at a level of care and then step down to lower levels of care based on your response. That was part of the goal of the fourth edition. And the fourth edition, interestingly, is shorter and simpler than the third edition. It actually is a more straightforward set of decision logic in making decisions around levels of care. So the idea was to improve clarity and simplify to support more effective implementation. I do not work at DHCS, and so I am not going to speak to exactly when licensing, drug Medi-Cal standards, and payment and data reporting is all going to align with the fourth edition. I've heard the year 2025 mentioned, but I will refer you to DHCS for the authoritative answer on when is what going to be implemented. But what I'm working on in LA is giving talks like this for our network, for our staff, for our team, to make sure that when this goes live, people understand this is what the fourth edition includes, right? The idea of socializing, this is what's coming. It's not present today, but when we go live, the vision is that nobody, certainly in this room, says, what's the fourth edition? Is it any different? that people will walk out of this with an orientation to what's coming in the implementation of the fourth edition of the ASAM criteria. So, one thing that was not strongly emphasized in the third edition, but which has been emphasized in the fourth edition, is access to addiction medications. Dimension 1, which has to do generally with intoxication and withdrawal risks, has been updated to also include addiction medication needs. And I'm not just talking about meds for opioid use disorder. Addiction medication needs includes meds for tobacco use disorder, because it's possible that some of the people you treat use tobacco products. And that is an addiction for which there are meds. So tobacco use disorder, alcohol use disorder, opioid use disorder, and addiction medication needs, of the way the fourth edition crafts it, is not just limited to meds that are FDA approved for alcohol, tobacco, and opioid use disorder, but clinicians should consider the full range of pharmacotherapy, including off-label meds that can be used to treat methamphetamine use disorder, cocaine use disorder, cannabis use disorder. They're not FDA approved for those indications, but they are addiction medications that could be considered. I'll go through, there's a new framework for the fourth edition, the different levels of care. But all medically managed levels of care, and I'll illustrate what that looks like, are to be able to initiate all FDA-approved meds for substance use disorder. And all FDA-approved meds for substance use disorder, not just opioid use disorder. I'm talking about, all substances for which we have medications that are clinically effective. All patients should have a physical exam within a reasonable time that assesses addiction medication needs. Reasonable time is such a funny term because I get asked, well, how many days is reasonable, right? ASAM will never tell you exactly how many days is reasonable. So I would refer to DHCS licensing standards on exactly what counts. ASAM does not have a position on a fixed number of days. But this is the way to think about it. Patients need a physical exam within a reasonable time that assesses addiction medication needs. So that means that every setting of care has to have a plan to get a physical exam, either directly, you have a medical clinician on site that can conduct those, or through referral, right? Because addiction's biopsychosocial, the medical part is a component of care. And that all clinically managed levels of care that may not have an on-site medical clinician have to be able to support continuing any FDA-approved meds. So that means the medical directors of clinically managed levels of care work with the team to look at protocols for everything from med storage and residential sites to plans to continue meds. And that could even be through referral to community-based organizations. That's fine, right? But that there's a plan to support continuing any FDA-approved medication. So Ooh, that turned out a little different than I thought it would in the projection. But anyway, so the fourth edition development process followed, the following methodology. There were 17 writing committees that did structured evidence review. There was a review of the third edition standards, and then there was the set of draft standards and decision rules. Then the fourth criteria steering committee did a rating and reconciliation, then put out a draft for public comment. So that draft for public comment went out well over a year ago. And then there was a revised version of the fourth edition. Our board approved it mid-2023. And we have narrative chapter field reviews, and there's actually additional editions of the fourth edition forthcoming. This is a very busy slide that goes through the stakeholder outreach and the 3,000 comments that ASAM received on the fourth edition, the draft fourth edition. And so there was public comment period 1, initial thoughts on the third edition, comment period 2 on the proposed major changes, and then comment period 3 on the proposed standards and decision rules that then generated and fed into the final version. So if anyone says, this was put together without input, this actually was put together with a fair amount of input from the field. So this is just the governance and oversight. So the board of directors, which I'm fortunate to chair during this term, approved the major changes, and this was how this fed into ASAM governance. All right, assessment standards. So the fourth edition describes standards for a level of care assessment. Where does the patient go next? That's a level of care assessment. Where does the patient go next? And then there's a treatment planning assessment. Once there, what treatment does the patient receive at that level of care, right? So they are related, they're interrelated, but they're not identical standards. So does this patient need to go to a hospital? Does this patient need to go to a residential? Does this patient need to go to a high-intensity outpatient? To be able to then get the treatment components that are part of the treatment planning assessment. Both assessments factor in the multidimensional, the 6 dimensions, and consider the patient's full biological, psychosocial, and sociocultural context in care. So there are new dimensions in the fourth edition compared to the third edition. The third edition, intoxication withdrawal potential, that's dimension 1. Dimension 2 is biomedical conditions, complications. Dimension 3, EBC, emotional, behavioral, cognitive conditions and complications. Dimension 4 is readiness to change. Dimension 5 is relapse, continued use, and problem potential. And Dimension 6 being recovery living environment. Those are the third edition. Many of you that do ASAM assessments will know that we'll be very familiar with these dimensions. The fourth dimension in the third edition was readiness to change. And readiness to change, as its own dimension, didn't actually make a ton of sense in contributing to a level of care determination. Because readiness to change, what exactly? Readiness to abstain from a substance, readiness to take a medication for addiction, readiness to participate in residential, readiness to go to meetings, readiness to what? Like readiness to change as an independent domain. Actually dimension didn't make a ton of sense. Now, readiness to change is very important. We have to be patient-centered. But readiness to change is actually now built into dimension 1, readiness to change, the items addressed, the dimensional drivers in that dimension. And dimension 2 for biomedical conditions, readiness to change in that dimensional driver. So readiness to change is important, but it's now been integrated into the other domains and has been taken out as its own domain. So the fourth edition mirrors the third edition, Dimension 1, intoxication, withdrawal, and addiction medication needs. Right? Addiction medications has been kind of emphasized as a component of care in the fourth edition, Dimension 1. Dimension 2, the term has been simplified to biomedical conditions. Dimension 3, psychiatric and cognitive conditions. The new Dimension 4 is substance use-related risks, because there are specific risks depending on the substance you're using and the route of administration. The Dimension 5 is the recovery and environment interactions, right? So kind of the third edition, Dimension 5 is now Dimension 4-ish. The third edition, Dimension 6 is now Dimension 5-ish. And then the new Dimension 6 is person-centered considerations, right? Because person-centered considerations really does make or break whether patients engage in care, right? Have you factored in somebody's full ideas and values and preferences and context to make sure that when they're linked to care, they're linked to care that they'll attend and go to? This is the same information on a different slide. So this is a cleaner slide of the 4th edition, right? So just to reiterate, in the 4th edition of the ASM criteria, intoxication, withdrawal, addiction, medication needs, biomedical conditions, psychiatric cognitive conditions, substance use-related risks, recovery environment interactions, person-centered considerations. This is what is coming, right? So this is the new dimensions that are coming as we move towards the 4th edition of the ASM criteria. There are some sub-dimensions within these core dimensions. So intoxication-associated risk, withdrawal risk, and addiction medication needs. That's relatively self-explanatory within Dimension 1. Dimension 2, physical health concerns, pregnancy-related concerns, and sleep problems, right? Those being some pretty common domains that we see for people entering treatment. Dimension 3, active psychiatric concerns, including things where you might need to actually send somebody for acute psychiatric stabilization. That's like part of the ASAM criteria, is the possibility of actually somebody going to a especially mental health setting for stabilization before they proceed with substance use treatment. A persistent disability, which is not uncommon in our system. We see people, they don't need to be placed on an involuntary hold, right? But they have this persistent psychiatric disability that's going to impact their capacity to participate in treatment, and that just should be factored in. Cognitive functioning, right? Trauma, exposure, and related needs, because again, trauma is the rule rather than the exception. Most people entering substance use treatment have a history of and experience with trauma. And then psychiatric and cognitive history being a component of the new or updated Dimension 3. Updated Dimension 4, likelihood of risky substance use and risky substance-related behaviors, right? So an example of risky substance-related behavior, when somebody uses methamphetamine, are they also engaged in risky sexual practices, right? For which we have medical interventions that can help protect people from getting infectious disease, right? There's things that we can offer people. It's not necessarily a substance use behavior, but it's a substance use related behavior. It's just one example. Recovery environment interaction, so has to do with ability to function in the current environment. How safe is somebody in their current environment? What is the support of their current environment? And what is the cultural perceptions of substance use? The shorthand for Dimension 5, for me, is people, places, and things. Right, the external triggers for relapse. But it's not just people, places, and things. It also includes in what context does this person understand their substance use, and what are the cultural perceptions that then impact the person's substance use wherever they are, wherever they're residing. And then person-centered considerations. What are their preferences? Do they need motivational interviewing to become more ready for a otherwise medically helpful level of care or medically helpful component of care? Right? I could see as clear as day, here is the plan of care that would really help you. And the patient may say, no. I sometimes get asked, Dr. Hurley, what's the best med for addiction? It's the one the patient takes. Doesn't matter what the clinical trial shows. Patient won't take it. It's not going to be helpful. Does this person have barriers to care? I sometimes think, if I wanted to be an entrepreneur, should I open up a pet service? So when people go to treatment, they could bring their pets to me, and I would get paid in order to take care of them, right? That's honestly a true barrier to care for a lot of people. And it's not just pets. I mean, it could be family. There's a bunch of other considerations. And then the need for motivational enhancement, which is kind of what I referenced earlier. So that's what's built into the 4th edition multidimensional criteria. The 4th edition, has the subdimensions that sort of were mentioned there. So, dimensions 1 through 5 are usually then developed with a level of care recommendation, and then dimension 6 actually shapes the placement, right? So somebody could say, with using dimensions 1 through 5, okay, what would be medically necessary is a residential level of care. And if somebody says, there is no way I'm going into residential, but I will talk to your counselor in an outpatient setting, then maybe you actually have the patient talk to a counselor in an outpatient setting that determines the sort of actual placement with the goal of then readying that patient for the otherwise medically necessary level of care. So in other words, Dimension 6 sort of takes what would otherwise be like using decision logic, be the optimal level of care, and then actually helps inform the specific placement along the continuum. Patient arrives, there's a treatment planning assessment that generates a treatment plan. Then you look at the patient's response to that treatment plan and then reassess, that then determines is ongoing care at, I'll keep picking on residential. Is residential continuing to be medically necessary? Is this patient ready to step down to non-residential, right? This is how the 4th edition of the ASAM criteria is designed to be used iteratively. Which also makes it tricky to say, well, you have to do ASAM assessments at X or Y timeframe. Like, you should be doing assessments on the basis of when the patient's condition indicates that they're ready to be reassessed, right? It makes, you have to do assessments every 15 days, 30 days, 90 days. It makes those fixed durations somewhat challenging to implement because really in the 4th edition, it's on the basis of what the patient would benefit from. And this is, again, a figure going through a patient's journey through the level of care. So level of care assessment, then the admission criteria shapes what level of care they go into, and again, there's this iterative process of reassessment. So, what are the levels of care in the 4th edition? They are not the same as the levels of care in the 3rd edition. Ta-da, here's the 4th edition levels of care. So the 4th edition levels of care includes a level 4, which is hospital care, medically managed inpatient. There is smaller boxes within these levels that talk about variations in those levels of care. So there's a medically managed level of care inpatient. Generally speaking, we're talking about a acute care medical surgical hospital or a chemical dependency recovery hospital that meets ASAM criteria for level 4, just for the sake of argument, for level 4. And then there's a psych version, which would be an inpatient psychiatric unit that meets the SUD standards, right? So the 4th edition of the ASAM criteria sort of includes acute inpatient psych as an example of a level of care that somebody might be matched to, depending on what's going on, particularly in Dimension 3, just as one example. So there's a hospital level of care. In the residential levels of care, there's a 3.1, which is low-intensity residential, 3.5, high-intensity residential, and then a 3.7, which is medically managed residential. And in 3.5 and 3.7, there's co-occurring enhanced standards for on-site psychiatric services. The idea that people don't, it's not just care coordination to outside mental health, but you actually bring components, right, minimum standards for specialty mental health services in that 3.5 or 3.7. So there's a co-occurring enhanced version. You might be like, but what about co-occurring capable? Every level of care is supposed to be co-occurring capable. There are licensed clinicians in our system that can make DSM-5 diagnoses and come up with a plan. And that doesn't mean that there's an on-site psychiatrist that's delivering psychiatric treatment or that there's necessarily an on-site LPHA doing psychotherapy for somebody's mental health condition. That would be co-occurring enhanced. But co-occurring capable means that every level of care should expect to be able to manage not less than mild to moderate mental health conditions when they emerge. And co-occurring enhanced is enriched mental health capacity. You will notice there is no 3.2 withdrawal management in the 4th edition of the ASAM criteria. You will notice there is no 3.7 withdrawal management in the 4th edition of the ASAM criteria. Spoiler, there's no 2 or 1 withdrawal management in the 4th edition of the ASAM criteria. Withdrawal management is not a level of care anymore in the 4th edition of the ASAM criteria. It is a service that somebody gets when they are at another level of care. So you can be admitted to a 3.7, medically managed residential. According to ASAM, 3.7 are not hospitals, they are residentials. That's, according to ASAM, that's the ASAM standard. These are residentials with on-site medical staff that can do withdrawal management, but that's not the only reason that you go to a 3.7. There's people with medical comorbidities that you might need on-site medical care. There's a biomedical enhanced version of 3.7, a residential that can do IVs and wound vacs, like a pretty advanced set of standards in the 3.7 biomedical enhanced version of 3.7. Not every 3.7 has to have that biomedical enhancement, but just to give you an idea, that's the standard that the 4th edition is set for 3.7. And so one question, what happens to 3.2s? If I'm running a 3.2 right now, where does that go? Well, talk to DHCS, they will tell you. The ASAM answer, which DHCS is not bound by the ASAM answer to this, but the ASAM answer to this is you would do 3.2 as part of a 3.5. If you look at the number of hours people get typically in a 3.2 withdrawal management, it matches the number of hours people typically get in a 3.5. So you would be doing withdrawal management during the 3.5 admission. But this is a very different way of thinking about withdrawal management as a service you get at a level of care. It's a part of care as opposed to a level of care. So I just wanted to name that. That's a shift from the 3rd to the 4th edition. The new level 2s, there's a 2.1 intensive outpatient, 9 to 19 hours a week. So it follows the same service standards as the 3rd edition. 2.5 is 20 or more hours a week of high intensity outpatient. And then there's a new medically managed intensive outpatient with on-site medical services where people are getting those alongside high intensity hours of care. You'll notice there is no narcotic treatment program, aka opioid treatment program, level of care within the 4th edition of the ASAM criteria. But the ASAM decision logic, if an OTP, hypothetically, was doing 9 or more hours a week, then they could, according to ASAM criteria, fit into the 2.7 level of care. In other words, the 4th edition of the ASAM criteria accommodates OTP services. They're just not sort of named as a distinct entity. So depending on the hours a week, it could be a 2.7 or 1.7 because OTPs have on-site medical care, right? Like they're dosing patients with meds and have medical directors there to do physical exams and assessments and make diagnoses, right? So that would fit, assuming all of the other components within the 4th edition are met, into a 1.7 or 2.7. What we have thought of as 1.0, which is outpatient care, in the 3rd edition is now 1.5, outpatient therapy. That is the new level of care. And there's a new 1.0, which is long-term remission monitoring. This is kind of an open-ended level of care with no fixed end, where somebody can go for toxicology tests if that's part of their plan of care, then go get additional counseling, they can go get groups, they can go get recovery support. Sometimes I get asked, where's recovery services in this, right? Is recovery services a standalone level of care? Recovery services are actually a set of services, right? They are not a level of care according to ASAM in the 4th edition. They're a set of services that you can get. Each level of care should have some recovery services to support people's connection to and supporting transition into recovery. But long-term remission monitoring, I think, would be a great spot for somebody who is in remission, but maybe has experienced some challenges and they need some help. They don't necessarily need to be admitted to like a, residential, right, in order to get some support. But this provides a sort of easy access, long-term support monitoring that doesn't have a fixed end because for most chronic diseases, treatment doesn't have a fixed end. We continue to support people with ongoing connections and support. And for the first time, ASAM has now defined recovery residences as a component of the continuum, right? The need for somebody, when they're not in residential, to have a place to stay that is supportive of their recovery. The decision logic now includes placement in recovery residences as a component of care, largely based on the new Dimension 5, which is recovery and living environment. So this is the 4th edition of the ASAM criteria. So a few things. 0.5 is not a standalone level of care any longer. Early intervention, the idea in the 4th edition would be built into outpatient therapy. 3.3 is also going away as a standalone level of care. 3.3 was cognitively a modified pace of treatment in residential for patients that might have cognitive conditions such that they needed a different pace of treatment. But adapting the pace of care to a patient's cognitive conditions is not actually a level of care. We should be able to do that at every level of care, not just in a 3-3. So again, it's important for us to be able to adapt care to people's cognitive capacities, but that is no longer a standalone level of care just in the residential intensity. The idea is that would be a service that would be available throughout. So it's been taken away as a standalone level of care. 3.2 withdrawal management, again, according to ASAM, you can go to DHCS for the authoritative transition, but integrated into level 3.5. Recovery support services are at, again, every level of care. That all levels of care are co-occurring capable at a minimum with designated levels of care that can be co-occurring enhanced according to the ASAM criteria. And I do want to take a second to talk about harm reduction. If I could summarize, harm reduction is a non-judgmental approach where you meet people where they are. And when you meet people where they are, you don't leave them there. The idea is we support people making the changes they're ready to make, even if somebody might not be ready to do all the things that I would want them to do. Harm reduction is an expectation that we are supporting people making helpful changes, even if they're not ready to completely commit to abstaining from alcohol, tobacco, cannabis, and all other intoxicants for the rest of their lives. That is a pretty big lift if we ask people to essentially be ready for remission in order to start treatment to get them ready for remission. It's a little bit like saying to a patient with diabetes, we will treat you with meds and diet and exercise once your blood sugar is fallen. Or we will treat your high blood pressure once your high blood pressure is down. With addiction, we have to actually, to reach the huge numbers of people in our communities that need our help, requires us to engage people before they're necessarily ready to do all of the medically recommended things. We have a history in addiction treatment. Call me when you're ready. Well, ready to what exactly? Right? Call me when you're ready. And in the worst overdose crisis in California history, call me when you're ready is too now frequently. People die before they're ready. And nobody recovers if they're not alive. So, part of the ASAM criteria, and we actually have an entire now clinical considerations document that will be publicly unleashed in September, around clinical considerations for engaging patients that might not be ready to stop using drugs in care. And that means that, one of the questions I ask somebody, and I'm a prescribing clinician, so I will start with the meds, but I'm not just talking about meds. If somebody has an opioid use disorder, I might have a conversation. Hey, do you want a medication to help you reduce your cravings, to help you stay out of withdrawal, to help you use less? I'm not saying you don't have to use. I'm not saying you should or shouldn't use. That's your decision. But are you interested in trying this med that might help you make some progress? The key to receiving the medication service is a willingness to receive the medication service. It's not a commitment to abstain or to do other things on top of that. Now, I want patients to do a lot of other things on top of medication services, right? But the medication-first approach is I start with where the patient is ready. Do you want to talk to a counselor? Doesn't mean that you're ready to commit to stop using drugs forever, but it's the first question is, if you want to talk to a counselor, are you willing to talk to a counselor? If you are, then that's what the patient gets at that point. The idea is, again, harm reduction. We meet people where they are. We don't necessarily leave them there. We help people make changes in their lives that improve their health and wellness, even if they're not ready to stop using entirely. The continuum, you've seen the new levels of care, are designed to try to align service hours, right? So it's always been kind of, not tricky, but if you go from a 3-1 level of care that might have fewer hours a week in the third edition than an IOP level of care. Like there's this sort of, you're dropping off from fewer hours of treatment a week to an area with higher hours of treatment a week. The service standards within the fourth edition are designed where people don't have these sharp drop-offs in the hours of care that they're receiving. In 3.1 and 3.5, structured services should be available 7 days a week. So in the fourth edition, there are not weekends off, right? There are some services available. And it aligns clinical service standards, right? So there's this now, 4, 3, 7, 2, 7, 1, 7 level of care where the expectation of initiation and management of medical conditions can be delivered. Dimension 1, as I mentioned, includes addiction medication needs to support the delivery of SUD treatment. And addictions are treatable with meds. They're not the only treatment, but there's meds that treat addictions. All medically managed levels of care should be able to initiate all FDA-approved meds for substance use disorders. All patients should have a physical exam, again, according to the ASAM criteria, within a reasonable time. That's as specific as we're going to get within the 4th edition to assess addiction medication needs. And all clinically managed levels of care have to be able to continue any FDA-approved medication. Level 1, this sort of spells out what I went through earlier. Recovery management. Checkups is part of this long-term remission monitoring, and rapid re-engagement of care. So the idea is there's a touch point that if somebody's like, hey, I'm really not using well, I began to use, maybe they haven't had a full re-ops, but like there's some slips, right? Somebody has like sort of begun sort of using or putting themselves in high-risk situations. The idea is you could then rapidly engage that person back into another level of care. Outpatient therapy is less than 9 hours a week of psychosocial services. That can include medical services, right? Medical services are allowable within 1.0, but medically managed outpatient encompasses everything that you would have gotten in the 1 withdrawal management from the 3rd edition. So the initiation and management of medications for withdrawal management, low threshold medication initiation with psychosocial services equivalent level to 1.5. So one could imagine a future state with community health centers that could be licensed, right, theoretically, right, FQHCs could meet a 1.7 level of care within the 4th edition of the ASAM criteria because they have on-site medical care. Early intervention and prevention are services, but no longer a standalone 0.7 nomenclature, right? So people can still access early interventions, but that can be delivered at a 1 or 1.5 level of care. The treatment of cognitive impairments, there's no longer a standalone level 3.3. Addressing individuals with cognitive impairments should be available across the continuum. And 3.7 is residential, according to ASAM. That is different than the current licensing standards, where 3.7 in the 3rd edition currently within DHCS is licensed as a hospital. According to ASAM, the 4th edition, 3.7 is residential. Withdrawal management is a service, not a level of care. I keep saying that, but I'll just keep reiterating it, right? So withdrawal management, biomedical care is available at 1.7, 2.7, 3.7, and 4. Now, that also means, in my view, you could do residential withdrawal management in 3.5 as well, right? So these levels of care have on-site medical services. For 3.2, which was the availability of protocols to do medical services, maybe not prescribing clinicians on site, but protocols to deliver medications in a residential setting, that can be delivered in a 3.5 according to the 4th edition of the same criteria. I mentioned this earlier, co-occurring capability. All programs should be co-occurring capable at minimum, right? Most patients have mental health symptoms, and roughly half of all patients have a co-occurring mental health condition. So we have to be able to diagnose and over time have some diagnostic clarity on does this patient have a co-occurring mental health condition for which medications and counseling and support for that mental health condition will help support their recovery from their substance use disorder. All right, so the expectation is that most patients have co-occurring conditions. Mild to moderate acuity, instability, or functional impairment should be able to be addressed at all levels of care with at least not less than 1 staff member qualified to assess and triage. These are our LPHAs, or licensed practitioners of the healing arts, that can make mental health diagnoses and develop plans of care. The idea is the treatment plans really are integrated, right? So it isn't the patient has mental health treatment at this place and substance use treatment at this place, but that the substance use treatment plan includes what are we supporting within the substance use treatment setting to support somebody's recovery that includes management of co-occurring conditions. And that might mean, according to the external mental health providers, that's okay. We still have a specialty mental health and SUD system, but it isn't, well, you go to mental health, do whatever they do, we're not going to pay attention. It's part of the plan of care. And program content should include particularly psychoeducation around co-occurring conditions. Recovery services, just as they are now within the current DMC ODS framework. Recovery services are available at each level of care. The dimensional assessment criteria should include the need for recovery residence support. If you're leaving residential and you don't have another place to stay while you go to outpatient, the idea is you are then placed in a recovery residence. And in Los Angeles, we've actually been running a recovery bridge housing program that does exactly that, right? That we have a placement, a county contracted recovery resident placement that a person can live in while they're attending non-residential care. Now, so the algorithm might now in the 4th edition say, this is a non-residential level of care, right? So 271510, or, this is the non-residential level of care plus a recovery residence. And there's a new chapter on integrating recovery support services, chapter 15. So I think I already mentioned this earlier, which is 2-1 and 3-1 are 90 to 19 hours a week, 2-5 and 3-5 are 20 plus hours of clinical services a week, and there's structured services 7 days a week in 3-1 and 3-5. That's in the 4th edition of the ASAN criteria. The idea is you don't just jump, you don't get an extreme jump as you move along the continuum. There's the new long-term remission monitoring. This is, again, level 1.0. And there's a big emphasis on recovery services at each levels of care to support people's ongoing transition. This also means, ideally, we're seeing formal affiliations. If you're not a treatment center that has all of these levels of care under one agency, that you affiliate with other levels of care so that there's a clear path. This is where it's time for you to step down. This is the plan for where we send patients to on the basis of what is clinically appropriate, and on the basis in the new 4th edition Dimension 6 that meets your preferences, right? So meets your language needs, that's responsive to your preferences and location and where you're ready to go and access care. So this box includes the clinically managed levels of care. Treatment planning is led by clinical staff, typically licensed clinicians, but not necessarily medical clinicians. The 2-1 and 3-1 provide, again, between 90 and 19 hours of clinical services per week that consists generally of counseling and psychoeducation. You can deliver medication services as part of this, but the medication service standards in the 3.7, 2.7, and 1.7 are on-site delivery of medication services there. With the 3.1, 2.1, 3.5, 2.5, and so forth, you have to have a protocol to support patients continuing meds that might be managed externally. The clinical expectations, again, are aligned. So 3-1 matches 2-1, 3-5, 2-5 match each other in terms of intensity. This is the medically managed care arm. So the hospital, the medically managed residential, medically managed IOP, medically managed outpatient are now a whole set of medically managed care. So this is a new thing in the 4th edition. Historically, substance use treatment programs haven't been considered medical. In fact, those of you that are in residential treatment are probably familiar with incidental medical services, which is a licensing requirement if you're going to deliver on-site medical services. It's not built in to your residential. So there are now, in the 4th edition, very clear expectations for integrated medication services across the continuum. Now, that doesn't mean that every site has to have on-site medical care. That's not what I'm saying. But there is a now defined set of medically managed care that falls along the same set of service intensities. And integrated care, right? So it's designed to promote whole person chronic care to integrate biomedical and mental health concerns. So you'll notice there's these co-occurring enhanced and psych versions where people can really get what we used to call dual diagnosis, what we now call co-occurring care or integrated care. Okay. Withdrawal management and biomedical services, again, are integrated into the main continuum. All programs are supposed to be co-occurring capable. Sort of made this point earlier. What does it mean to be co-occurring capable? Mild to moderate acuity, instability, or functional impairment can be managed. There's on-site licensed practitioners of the healing arts that can provide diagnosis and care coordination with integrated treatment plans, coordination with external mental health providers if you don't have that on site, and program content that provides psychoeducation and around co-occurring conditions. And then co-occurring enhanced, right? I'll just go back. Co-occurring enhanced being then the delivery of on-site psychotherapy and other evidence-based practices for mental health conditions. And then the chronic care model, long-term remission monitoring with recovery resident support to support people with check-ins and ongoing kind of unending care for when patients need it. Okay, a word about recovery residences. Recovery residences, so there's residential, where you go and you stay, and that's, again, 3.1, 3.5, 3.7. And then that's residential level of care. Recovery residences come in 3 types. There's supervised, monitored, and peer run. There's actually specific service standards along with a supervised recovery residence with professional staff that do on-site supervision. Monitored, which is there's a professional set of staff that do monitoring, but without the intensity of on-site supervision. And then peer run, which is generally a peer run kind of sober living model of recovery residences. How does the decision logic work in the 4th edition of the ASAM criteria? I'm not going to go through everything on the right. But I'll say the algorithm is actually simplified compared to the 3rd edition. So here's just an example. Somebody comes in for a level of care. They're in severe alcohol withdrawal and they have very high blood pressure. Those dimensional drivers within dimension 1 and 2 within a level of care assessment say, okay, this patient really needs to go to a medically managed level of care to treat their severe high blood pressure and their alcohol withdrawal. Fortunately, alcohol withdrawal and high blood pressure is actually pretty easily treated, right? Like there's meds and treatments that can actually get somebody out of alcohol withdrawal and get their blood pressure down pretty quickly, right? So initial plan of care, generally go to a medically managed level of care, depending on what other components in the multidimensional assessment determine, but to go get alcohol withdrawal management. Once that alcohol withdrawal and severe hypertension is addressed, then there's a regular reassessment, and as it turns out in the reassessment, the new dimensional drivers, the new things that are most urgent, is the fact that this person is very likely to return to risky substance use, and they have severe impairments in pro-social skills. They are not doing well in their milieu and in their lives. So this patient now with dimension 4 and dimension 5 is probably going to need some containment in order to be able to benefit from ongoing recovery. So at that point, they might be ready to step down from a medically managed level of care to a clinically managed level of care, 3.1 or 3.5, on the basis of the other components. So the idea is this is just an example of how dimensional drivers shape how a patient is placed at a level of care. The severity ratings in each subdimension are really a foundation, right? So the idea is, are there severe psychiatric or cognitive conditions or an unstable evolving mental health concern? So if somebody's meets 5150 criteria, they generally speaking need LPS placement, so that would mean some locked psychiatric placement in order to stabilize. But if they have an evolving mental health condition, actually then stepping down to a residential co-occurring enhanced placement that's voluntary, it's unlocked, but that has the on-site staff to be able to support their mental health concerns, their evolving mental health concerns, could be an appropriate placement, right? Transition to continued service criteria, right? So there's criteria for how long does a patient need to be at a level of care. The progress is expected, based on factors such as increased engagements or adjustments to the treatment plan. And the idea is we actually get patients out of more restrictive levels of care as soon as they're ready. I don't mean before they're ready, but I mean there's no point in keeping somebody in residential indefinitely beyond what they need, right? So if somebody needs to go to a higher level of care, it's because generally they haven't improved in a reasonable time frame or the patient has gotten worse. And criteria for transition to a less is the patient no longer meets the dimensional criteria for ongoing residential admission. And the idea is the patient could be effectively treated in a less intensive level of care. A few service standards and other changes. Universal access to overdose reversal medications on site. This accords with current DHCS policy. Essentially, everybody gets naloxone. Everybody gets naloxone. If you're in substance use treatment, you get naloxone. And it isn't because we expect everyone leaving treatment to overdose, but because in the worst overdose crisis in California history, you never know when you're going to be in a setting where somebody is overdosed. So when we have universal access to overdose reversal medications on site, it can be used to reverse people on site, and when we provide it to patients when they leave, it can be out in the community in a population that's at higher risk of overdose than the general population. Every level of care should be responsive to people's trauma needs, all right? most people that go to substance use services have experienced trauma in their lives, and that means being trauma sensitive. Understanding that there's oftentimes a lot that has gone in to people's journey into treatment, and we have to sort of understand and respect that people are coming oftentimes from a place of a fair amount of sensitivity around, prior trauma. Care needs to be culturally responsive. That means that across the levels of care, there's language support so that people can get treatment in their preferred language. And care coordination. A lot of patients need care coordination with court, physical health, mental health, DPSS, social services, right? There's a lot of care coordination that our patients benefit from. Clinically managed levels of care should have formal affiliations with medical providers to, not necessarily on-site medical services, but to make sure patients can continue medication services outside of a medically managed level of care, and that medically managed levels of care have to provide comprehensive psychosocial services. There's a few items of new content. Treatment planning, right? There's an entire chapter on treatment planning. There's a chapter on telehealth and other health technologies. The short of it is telehealth doesn't replace treatment, generally speaking. An app is not the same as going to a full treatment program. But telehealth is a way of extending treatment to where the patient is. So in other words, it's a modality, not a standalone service exactly. And other health technologies, actually, many of which have been developed designed to complement or boost or increase the stickiness of treatment or retention in treatment, can be very helpful. So we have a chapter on that. Integrating recovery services is chapter 15, which I mentioned before. There's a new chapter 16 on trauma-sensitive, culturally humble, and social determinants of health. Chapter 18 is regarding pain, which I will tell you is not terribly uncommon in our patients, particularly with opioid use disorder. Not exclusively, but typically. And then cognitive impairments. So that's some of the new content. The treatment planning chapter, the idea is that the clinicians work with the patients to develop SMART goals, specific, measurable, achievable, relevant, and timely goals that address the dimensional drivers, reflect the patient's priorities for their care, are expressed in the patient's own words and can realistically be addressed at the given level of care, right? That's the key is I am so much better off when I can evoke from a patient their goals. I'll give you an example. It's a relatively innocuous example, but I like it, which is smoking. I don't know how many of you have met somebody that uses tobacco products who's been in treatment. The data suggests it's somewhere between 60 and 80% of the patients, depending on who you're talking to, right? So it's a ton of the patients in treatment use tobacco products. And I might say, tobacco products, my goodness, this causes stroke, this causes heart attack, this causes cancer, this causes emphysema, this causes da-da-da-da-da-da-da. I'm a doctor, so I just talk about all these health conditions. And the patient says, I don't care. I don't care, right? But if I start the conversation differently, I say, hey, use tobacco products. What changes would you be interested in making with your tobacco products, if any? And they might say to me, changes, what do you mean? I'm like, well, you smoke a pack a day. What about 2 packs a day? 3 packs a day? What about putting together like a scuba suit where you're only inhaling tobacco smoke all the time? And if I've said this right, they laugh. I say, Dr. Hurley, I can't afford that. And I know it's bad for me. And now all of a sudden, they are talking about the reasons that they don't want to smoke more. And I'm so much better off understanding from their perspective. And their perspective it may have nothing to do with health. It might be, I don't like the way I smell after I smoke. And I don't like the fact that my grandkids recoil when they come up to hug me. I don't like the fact that I huff and puff when I go up a flight of stairs. I don't like the yellowness on my teeth, whatever it is. Ideally, I am now putting a plan of care in the patient's own words. Patient wants to be able to walk up a flight of stairs without huffing and puffing. Patient wants to save money on cigarettes. The patient wants to not have yellow teeth. That is a much more patient-centered perspective, right? Than a patient agrees to not stop smoking because of their health, because that may or may not be actually like true from their perspective. And when I can, people are so much better persuaded by the ideas that they have than by anything I say. I mean, let me just tell you that straight out, right? I have a lot of ideas. I can't tell you how many times I just sit there and talk. It's one ear, out the other ear. A lot of people don't listen. But if I can take a moment to understand and evoke from somebody their ideas and values and intentions, I can actually be effective at engaging somebody in helpful change. Treatment planning is continuous. What's working? What's not? How do I know it's working? I know it's working because the patient's responding to it. I know it's not working when the patient isn't. Does new information indicate the need for different strategies in a more intensive or less intensive care? And again, the goals, objectives, and action items are based on a patient response to care. I regret ASAM still has not defined exact timeframes over when exactly a new treatment, or a new assessment needs to be done. Like that is, the ASAM criteria talks about the standards, but it is a clinical decision over this is what's going on in the response of the patient and when it's time to adjust the plan of care. Additional volumes that are not here yet include an adolescent and TAY, or transitional age youth volume. It's not published yet, so we're in this, ASAM, I'll own it for ASAM, is in a somewhat awkward position of having a 4th edition for adults and a 3rd edition for adolescents and transitional age youth, currently. That's the current state, right? 4th edition for adults is published. Adolescent transitional age youth is expected in 2026. There's a correctional setting and reentry volume, and then behavioral addiction volume, because we sorely needed some guidance on everything from gambling disorder to other types of behavioral addictions. Fortunately, there's a whole number of implementation tools. So if you're like, hey, I went to the DHCS Integrated Care Conference, I heard Dr. Hurley talk, and it was great. Where do I get more? If you go to asamcriteria.org, it's actually a sort of one-stop shop website where you can find where you can purchase, because it's available through purchase, an electronic or paper-based version of the 4th edition. But there are, for free, PDFs that go through a few like standardized forms and the new levels of care. A lot of what I presented here is available for free. In fact, this slide deck you can download as a PowerPoint. So if you want, hey, I want to go deliver this slide deck at my treatment center, at my state behavioral health department, at, this slide deck is, you can absolutely use it. It's available for download through the asamcriteria.org. And then there's a number of courses that are available. I'm finishing up review on a utilization management set of modules, right, for the 4th edition of the ASAM criteria. So the point is ASAM is producing a lot of implementation tools to help our state go exactly in the direction where we need to go, which is fidelity to the 4th edition of the ASAM criteria. I think I have roughly 20-ish minutes left for questions. So this is my email address if you have any questions. If you were like, this is great and I want more, of like talking and stuff. The ASAM meeting is going to be in Denver this coming April. Next week, the California Society of Addiction Medicine meeting will be in San Francisco. I'll be there if you can make it up. And then addiction psychiatry is going to be in Naples, Florida this coming November. Thank you, everyone, so much for your time and attention. And then we got about 20-ish minutes to hear your questions, concerns, thoughts, feelings. I'm ready when you are.
Testing 1, 2. I have a question back here. Straight in the back. Right.
There you are.
Thank you for the presentation. I've been a big fan of ASAM and the ASAM criteria for a long time, and I always live with a frustration. And this is the frustration, and that is that the ASAM criteria is theoretical, and we who are providers live in a very practical world that's driven mostly by managed care organizations. And so when standards are established in a theoretical context that people who live in a practical world strive to attain, it creates a condition for frustration and organizational challenges that feel insurmountable. For example, the 3.5 wonderful theoretical idea of having a licensed therapist in a treatment program that's funded by Drug Medi-Cal with a managed care organization does not reimburse for licensed therapists sets up a condition for failure. So my question is, what kind of practical ideas do you have for providers who can embrace the ASAM criteria in a way that's meaningful where they live and work?
I really appreciate the question. I don't know that I'm going to be able to answer it perfectly, so I'm going to give it my best shot. When ASAM developed the 4th edition, a lot of the comments we got are the level of care standards being promoted are not feasible. They're not feasible because payment hasn't caught up. They're not feasible because this is not what we do. It's not, there's a bunch of sort of reports of that. And we think, in the way that we developed the 4th edition, that everything that exists in the 3rd edition has a home in the 4th edition. Like, we're not necessarily completely eliminating an entire treatment program's existence, right? It can sort of fit into the 4th edition. We also felt like it would do a disservice to the field if we just described what was, as opposed to describe what should be. And the nice thing about defining aspirational standards and aspirational levels of care is it does shape the field in that direction. We are seeing more medication services in our system of care than ever before. I think as a result of a lot of the promotion of the ASAM criteria to fidelity. So to answer your specific question, if I'm in a 3.5 and I have a licensed clinician doing psychotherapy in a 3.5, then the simplest answer, and I don't work for DHCS, so it's a little bit easy for me to say this, which is the rate has to support that. The rate has to support that. And one of the ways, because we work, and now I'm speaking kind of with an LA County hat on, we try to be very transparent in our work with DHCS over it costs, the actual true costs of delivering care with fidelity are different than the true than the sort of the way the cost reporting has been done historically, because we're talking about additional services. So one just clear example of the way that was operationalized in the latest round of rates was medication services are billable on top of the day rate, as just one example of a way of making sure those services are sustainable on top of the day rate for residential levels of care. I could imagine, I'm not speaking for DHCS here, but I could imagine a scenario where there's a financial case to be made for why the rates to do, particularly co-occurring enhanced, but even co-occurring capable mental health assessments would have to be built into the rates in order to make them sustainable. So in other words, I agree with you, right? I agree with you. But that's the work. And I don't envision there will ever be a future state where the payers are going to be beloved by the providers. There will always be a tension, and so I'm not trying to say that there won't be that tension. But I also think part of the 4th edition is advancing the field with a staffing model and service model that more closely represents the community need. So that's the best I can do in answering that question. Thank you for it.
We have another question over here.
Oh, thank you.
Hi. Thanks, Dr. Hurley.
Brendan.
Can you describe what ASAM is doing to work with managed care plans, specifically around payers that are not contracted for specialty mental or specialty substance use disorder services, like in Medi-Cal managed counties, to sort of maybe slow down the implementation of the new ASAM 4th edition standards, since the infrastructure doesn't exist yet in California?
I do not think ASAM will agree that not adopting the 4th edition is a good idea. I do think that ASAM will agree, and I'm speaking for ASAM, so we agree, that when fourth edition is implemented, it has to be implemented with fidelity. And so what I would say is, if there are payers moving forward with a fourth edition, say, utilization management framework, but it doesn't match the current licensing framework, then I think there's a very clear, mismatch there. So ASAM has a couple efforts with respect to managed care that I'll highlight. We are doing fidelity monitoring, or let me take a step back. We are preparing to do fidelity monitoring, where any entity that says they are following the ASAM criteria, we have standardized patient scenarios where we'll run it through an individual algorithm and say this will or won't work. That doesn't address the licensing issue, by the way, but that's one way that we're planning on making sure that the payer fidelity doesn't inappropriately restrict access to care. I think it's a very good point if you have a payer who's saying, we've adopted the fourth edition, but if the fourth edition has different levels of care than the third edition, it's not practical to do that. So I think it would be a very clear argument for why that payer would need to delay implementation until such time as those licensing standards are updated. And we do actually have a payer relations committee as part of our advocacy team. And we put out a number of public policy statements specific to managed care coverage. So if there are a number of payers that are getting ahead of licensing and putting together service standards that sort of don't exist, to sort of the point made earlier, like your algorithm for utilization management in your non-drug Medi-Cal payer source is recommending and requiring services that don't actually exist according to licensing standards, I think that's a very clear argument. And typically, just transparently, when there are national payers that are doing this, ASAM, we can write letters or help support with individual advocacy, but I don't want to overstate our capacity to get involved with every treatment center's individual situation. And if it's a state payer, usually CSAM, California Society of Addiction Medicine, ASAM does have a state advocacy team that can help support if there are state audiences that need that kind of information. But what I don't want to misrepresent is that ASAM is regularly on the phone with every single payer and every single provider and navigating that. But I would say ASAM's position is that we support the implementation of fourth edition with fidelity, and I can completely understand if you're an agency operating a third edition level of care, because that's what your license is, but your non-drug Medi-Cal payer is saying, well, we're only going to pay for the fourth edition standards. That's a clear mismatch. Yep.
Another question over here.
Yes.
So our current withdrawal management 3.2, we have folks that are coming in and their impairments due to their withdrawal symptoms are such that they can't meaningfully participate in treatment services in 3.1.
Mm-hmm.
So if we take away that level of care and people are theoretically in 3.1, how are they meeting medical necessity for that level of care if they can't participate in the treatment service?
So within the evolution from 3.2, I think the thought from ASAM was that most 3.2s would go to 3.5 because the medication services that somebody's participating with count against those service hours, right? So the idea is it's not just group attendance, but it would be individual counselor check-ins, care coordination, which is oftentimes needed up front, and the medication services will all count against those service hours, even if you're not, say, going to group because you're too impaired from your withdrawal.
So we have a lot of people that are coming into withdrawal management that maybe not want medication services, and they need that monitoring while they're coming off of substances. And so that's just kind of a difficult, where do they go?
So medication services in the fourth edition are required to be offered, not accepted, right, but offered, right? So the offering of medication services counts as a service even if the patient doesn't take it, right? But you would document you've discussed the risk benefits alternatives around medications. I'll just name it, methamphetamine withdrawal, for which there are no medications used for, say, methamphetamine withdrawal. The containment of you could admit somebody 3.1, 3-1 requires, not less than 9 hours a week. So that would mean like a check-in, right, with that person, say, a few times over the course of a day for monitoring would count towards that service hours, even if the person's not like in group or getting psychoeducation or psychotherapy. So that's how I would envision, like you could give somebody a place to sleep and rest from their, hypothetically in this case, methamphetamine withdrawal, and the time that staff spends with the patient, like, conducting assessments, and oftentimes you might be doing assessment over the course of many days, right? Because you only get a certain amount of time with somebody at any given point would count towards those service hour requirements. Even if they're not like attending the structured services exactly as would have otherwise been recommended and call it a standard 3-1. Does that make sense?
We have one other question here.
I'll get there eventually.
Hey, so obviously I agree with everyone. There's a great level of value in advancing the best practices and the general principles that we're discussing. But the devil's in the details. The devil is always in the details, and it's going to take quite some time and a lot of work from a lot of different angles to implement. For those of us who are interested in, say, pitching pilot programs to DHCS and grant programs and private payers, what level of assistance or support is ASAM willing to give for kind of interesting projects like that? No, I'm not asking you to promise something specific, but generally speaking.
Well, we have a set of published implementation tools that we would point you towards. I mean, honestly, so one of the, we recognize that there's a whole lot of change involved with going to the 4th edition. We get that. And so we're producing a lot of materials with the idea of supporting that. I have every expectation that California will have a California version of the 4th edition. You know what I mean? It'll be very contextualized to our system, as it needs to be, right? As it needs to be. And I think ASAM is always interested in hearing, right, around what's the innovations and what's being piloted. But I don't want to overstate the capacity of the existing ASAM staff that's really busy working on kind of just the standard stuff to be able to directly assist or participate in local implementation. But I'm here in California, be excited to talk to you around what you're thinking and seeing if there's an opportunity or home. It may not necessarily be as an ASAM product or as an ASAM thing, right? But informed by partnership with ASAM and what we work on.
And one question from the back.
Question in the back.
Yes.
Hi. I first had a comment of just expressing appreciation for the emphasis that ASAM is placing on treatment planning. In California, there's been some debate and shifting of policy regarding that in the mental health side particularly, with the advent of what's now called the problem-oriented record. And I hope that this emphasis that ASAM is placing will help to influence policy on the substance use side, at least in California, to preserve the importance of attention to treatment planning that you pointed out. So thank you very much for that. Yep. Regarding the change in a level of care designation for withdrawal management, I'm still trying to digest that.
Sure.
In my read of and working closely with the 3rd edition over the years and implementation, there seems to be, especially in residential treatment, a differentiation between the different levels based less on the amount of hours and more on the level of acuity of the patient as to where they were placed. So it was conceivable in the definitions in 3rd edition that someone could be in level 5 and actually be receiving less hours in a certain week than somebody in 3.1. In this current edition, it seems like the level of acuity is getting less emphasis than number of hours, so that level 3.5 can be equated with 3.2 WM.
Right.
And in my reviews of a number of programs throughout California, especially when I was with the EQRO, that those organizations that had combination of level 3.5 and 3.2 WM in the same building, we're having to be very careful about physically separating them. And when that wasn't the case, it was incurring a lot of problems because of very different standards of care that were necessary for how closely somebody was monitored, how rapidly somebody was given attention at 3.2 WM because of a higher risk level that they were undergoing at the time. So I'm hoping that, and I haven't read this 4th edition, I'm hoping that you'll be distinguishing between and acknowledging the needs for different standards of care for withdrawal management at level 3.5 than treatment, because I think there are some profound differences that are there, and they extend also to staffing levels, to all kinds of things.
So I really appreciate the comment. That's super thoughtful. In this slide deck, there was a strong emphasis on hours per week alignment to demonstrate the sort of numerical alignment, but I did not mean to imply that acuity was not, not a factor in placement. It absolutely is, particularly in accordance with the dimensional driver sort of framework within the 4th edition. So acuity absolutely has then an impact on placement. This does, for what it's worth, sort of push how 3.5 is organized, where what happens with a patient over the time of their 3.5 admission is going to evolve. And in fact, there's some 3.5s that might actually be 3.7s with medical staffing. There's some 3.5s that will remain 3.5s with coordination with, say, offsite medical services. And it is, frankly speaking, not just about hours a week. It is also about acuity. When you do get into the details of the 4th edition, I would love to have a subsequent conversation about how you see, given your prior platform with EQRO, how you see this being deployed in the state, because I would appreciate your reflections, and thank you.
One more question over here.
Yes.
Great, thank you.
I come from the community health center side of the house where the barrier to entry is fairly low. And I think what I've always been struck with, and while I really applaud, this kind of what ASAM is setting as a standard, the entry into the DMCODS system and the requirements for the assessments are quite high barrier, and that kind of goes against, I think, where we're all trying to head. So kind of your thoughts on that, where can we go in terms of living up there but living down here too?
Yeah, so there was a time in DMCODS where you had to have a comprehensive ASAM assessment from the get-go, plus a Cal-OHMS, right? So we're talking hours, right? Let's just be clear, right? You're talking about a fair amount of time, as somebody's first step of care. With BIN, 21075 and then BIN 2301, forgive the bureaucracy speak to those of you that don't speak bureaucracy. For non-residential levels of care, there was actually a 30 to 60-day window under which somebody could start services prior to even a diagnosis, right? The idea is creating that low barrier to entry. So in my county, we created an entire actually separate framework, authorization framework, where somebody could begin to submit claims for care prior to an ASAM assessment, prior to diagnosis. The latest BIN, the BIN 23068 and then 2401 have taken away those exact timeframes, and now it's the initial assessment needs to be conducted as soon as it's feasible, right? But there's some flexibility on that. So I actually have seen the state, even in the 3rd edition, create a fair amount of flexibility on when a comprehensive assessment needs to be conducted. And my own view is we need to start treatment wherever the patient is, kind of whatever they're ready to do first, as the foundation of then going ongoing assessments. That'll be, so in LA, you can get paid for a certain amount of time of non-residential care even without an ASAM assessment. That currently exists. And that is accordance to the current state standards for non-residential care. So that's just one example, and I think in the 4th edition, it's followed very similar language over as soon as it's feasible, as opposed to everything has to be done first before you start care, which is, there has been a historic, that was kind of the initial setup, but that's actually, that does not accord with the current version of the 4th edition of the ASAM criteria. I'm out of...
And Doctor, we have just one
more
question, and that is the end of our questions. Sorry, guys.
Great, thank you. And I also just want to express appreciation for ASAM for kind of bringing us up to this next level and the thoughts around including harm reduction. Very excited to see how recovery residences is built into everything. Curious to hear about how family considerations are moving in there. But the question that I wanted to ask you is sort of wearing your other hat, your LA County hat, kind of going up a few steps. How do you see this rolling out?
So I'm very excited to learn from DHCS how the licensing standards are actually going to, there's one thing to be talking about the new levels of care, and then like what is the actual published licensing standards? How is that going to align with data reporting rates? Like that's just frankly in my LA County hat what I'm really looking forward to working with the state on. And I just wanted to say a lot of appreciation to DHCS, who's been a very helpful and collaborative partner in all of this. So thank you for that. Thank you. Very last thing, I know I mentioned harm reduction earlier. So DHCS is actually hosting a series of harm reduction summits for DHCS licensed and certified substance use treatment networks. There's going to be a series of regional summits. I'll be leading 2 of them myself, but there's others that'll be leading to really help advance this engagement and retention of non-abstinent patients in care. So I just wanted to say, this is something DHCS is actively working on in partnership with ASAM. We're very excited for these regional summits. You'll be hearing more from DHCS and, and ideally from your county behavioral health systems. So thank you everyone so much for your time and attention here this morning.
All right, I know he says he doesn't work at DHCS, but he knows all of our form numbers, our bins. He's plugging our harm reduction summits, and I think that's really a great place to land. If you are interested in those, we talked about some of them are rolling out this fall, so please look on our website for those, and we hope to see you there, and we hope to see you next year in 2025. So thank you all, travel safe.